Hi, my name is Stephanie Hertz, Marketing Director here at Warwick Forest. Warwick Forest is the premier sponsor for CNU's Lifelong Learning Society, and we welcome you to the Riverside Lecture Series. Today, I have the pleasure of introducing Dr. Kaitlyn Proctor. Dr. Proctor is a family medicine resident currently working at Riverside Regional Medical Center. She's originally from Fredericksburg, Virginia, but has been living in Newport News, Virginia since 2021. She received a Bachelor of Science in Chemistry from Virginia Commonwealth University in 2015 and received her Doctorate of Osteopathic Medicine from Edward Via College of Osteopathic Medicine in 2021. She is currently completing her residency at VCU Riverside Family Medicine Residency Program. Dr. Proctor has been working as a resident physician at Riverside Regional Medical Center since June of 2021 in both an inpatient and outpatient setting, working with patients of all ages. Her goal is to continue to work with both adults and children at a local private practice clinic here in Newport News. Dr. Proctor's favorite activities are to explore new restaurants with her husband, friends, and family. Please welcome Dr. Kaitlyn Proctor as she speaks about cancer screening and prevention.
Alrighty, so I'm Kaitlyn Proctor. Today I'll be speaking about cancer screening and prevention. So what is preventative cancer screening and why is it so important? Screening tests help find cancer early, before you have any symptoms, and oftentimes this makes the cancer easier to treat. Personal risk factors such as family history, race, ethnicity, and genetic conditions may place you at a higher risk of getting cancer. You may be recommended to begin screening at an earlier age than those at average risk. Risk factors are divided into two categories: risk factors you can control and those risk factors that are out of your control. Some examples of risk factors you can control would be alcohol use or tobacco use, while things you can't control may be your genetics. You don't have much control over your age, so those are just things to keep in mind. The goal of all of this is to protect you and your loved ones. So understanding the recommended guidelines for people at average risk of certain cancers. We'll start with breast cancer screening guidelines. Again, these are for patients and people of average risk. If you have a higher risk, these recommendations may change. So for females ages 21 to 39, breast self-awareness is extremely important. You should know how your breasts normally look and feel and report any changes to your healthcare provider. Ideally, your primary care provider or OBGYN should be performing a clinical breast exam every 3 years. If you are of the age of 40 or older, again, breast self-awareness is very important, but we do increase the clinical breast exam to every year. And after the age of 40, we start recommending a mammogram every year. We do have other imaging options, such as ultrasound for those before the age of 40, and those of higher risk can often receive MRIs. Colorectal cancer screening guidelines, again, for average risk individuals. Starting at the age of 45, we start recommending patients have a colonoscopy every 10 years. A colonoscopy is the only test that can prevent and detect colorectal cancer. We do have other options for screening. That includes a Cologuard, which is a home-based stool DNA test. The company mails you a kit. You give them your sample and send it through the mail, and they check for the DNA often found in colon cancer. There is another option, the fecal immunochemical test. That's a FIT test. That's every year. Again, it's based off of a stool sample. Something to keep in mind, if you choose to go through the Cologuard or FIT testing, if these are positive, you automatically are required to have a colonoscopy because the colonoscopy, again, is the gold standard. We can see polyps or other cancerous causes, treat them right then and there by taking a biopsy, And then we are one step closer to treating colon cancer at that point. Lung cancer is another cancer that we can screen for. Current or former smokers between the age of 50 and 80 should be screened with an annual low-dose CT screening to detect lung cancer. You should have a low-dose CT if you have smoked an average of 1 pack per day for 20 years, are currently smoking or quit less than 15 years ago, or you currently smoke and have other risk factors for lung cancer. This is a very easy test. Go to an imaging facility, they do a quick CT of your chest, and they are able to see if you have any nodules or masses that are concerning for lung cancer. They do use a lower dose of radiation for these testing. So I know a lot of people are concerned about radiation risk, but if it catches a lung cancer sooner and they're able to use a lower dose of radiation, I think that's definitely worth the risk. Next up is prostate cancer. Always talk to your healthcare provider about your own personal risk factors to see if screening is for you. Prostate cancer is a cancer that we use mostly shared decision-making between the patient's family, and the provider. Age 50 for men is when we usually start for those with average risk. If you are a higher risk gentleman, we start at age 45. This includes African Americans, men who have a first-degree relative diagnosed with prostate cancer at an age earlier than 65. We do start screening at age 40 for men at an even higher risk, which are those with more than one first-degree relative who had prostate cancer at an early age. Prostate cancer screening is very straightforward. It is a lab draw, just a blood test where they check your prostate-specific antigen. There are risks and benefits such as false positives, false negatives, and this is something you want to discuss with your primary care provider. Cervical cancer screening begins, this says age 25. We actually start at age 21 at our practice, but we start with a pap smear and HPV co-testing, meaning we test both at the same time. We do a repeat pap with HPV co-testing every 5 years, or a pap smear without HPV testing every 3 years, and that's between the ages of 25 and 65. For those age 65 and older, with a history of an abnormal pap smear or other abnormal cervical conditions, you should always talk with your primary healthcare provider about recommended screening intervals. Many women find that screening for cervical cancer is a pretty straightforward process. It does involve a pelvic exam, but if this gives you the peace of mind that you don't have cervical cancer and can go another 3 to 5 years without worrying about it, it is quite beneficial. Yes. So the question was, if you're after the age of 65, and you don't have a history of abnormal pap smears, a lot of times, can you stop doing your cervical cancer screening? And you're correct. If you have no abnormal pap smears, no family history of cervical cancer, you can often stop screening after the age of 65. This is a discussion to have with your primary care doctor. If you're 65 and still biking every day and going for runs and living your best life, continuing to screen for cervical cancer at that age, catching it early and being able to treat it early rather than waiting for an issue maybe around age 80 and finding it out later on, that's a risks versus benefits conversation with your primary care doctor. Cervical cancer screening is very straightforward. And if you can catch it at age 66 and you are feeling up for the treatment, that's a good option for a lot of people. So the question was about the statistics, the percentage of people over the age of 65 that have cervical cancer. I cannot give you that number off the top of my head. As a primary care doctor and a resident, I do the majority of the screening for cervical cancer in my practice. If I do find cervical cancer, oftentimes I will refer the patient to OBGYN or gynecology oncologist. We do have one of those locally. and they would be able to give you a better guideline of statistics. It is less likely that you will develop cervical cancer at a later age, but that's why we start screening earlier. Cervical cancer is often caused by HPV, human papillomavirus, which is what we test for in addition to the pap smears. At a younger age, your body is able to clear that virus easier. But if you are diagnosed with HPV, maybe closer to 65, your body and immune system has a tougher time fighting that virus. So I can't give you exact statistics. Your OBGYN or gynecology oncologist may be able to give you absolute number. The HPV vaccine is a great question. The HPV vaccine is proven to prevent the higher risk strains of human papillomavirus. We start vaccinating in early adulthood, even into some of our younger teenagers. I believe it's past the age of 12, and can do catch-up screening in females up to about the age of 40. We have seen that getting the HPV vaccine does prevent the higher risk strains of HPV. It does not prevent the more mild strains of HPV that cause cervical warts or warts on your hands and feet. And we're now seeing that HPV can cause head and neck cancer as well. So we do recommend getting the HPV vaccine. But again, this is a conversation to have with your primary care physician. Any other questions about HPV or cervical cancer? We'll move on to head and neck cancer. Always talk to your healthcare provider if you notice changes in your voice or hoarseness, a lump in your neck, persistent sore throat, difficulty swallowing, or mouth and lip sores that do not heal. If you use tobacco or drink alcohol, you should self-screen monthly and have a yearly clinical screen at your dentist appointment. A lot of dentists will see you every 6 months and can do routine screens while they're doing your routine dental cleaning. Always keep your preventative dental cleanings and oral exams. It is a very straightforward way to not only keep your mouth and teeth clean, but to screen for oral cancer. We have some skin cancer screening guidelines as well. Above the age of 18, we recommend you self-screen monthly and know how your skin normally looks and feels. We use something as easy as A, B, C, D, E to determine whether a skin lesion is atypical. A is for asymmetry. If one half is unlike the other half, you are at risk for this being an abnormal lesion. B is for borders. Irregular or poorly defined border indicates a more atypical lesion. C is for color. If it's varied from one area to another, especially in shades of tan or brown, black and red, white or blue, this is a lesion we would be more concerned about and bring to the attention of primary care or any healthcare provider. D is for diameter. The larger lesions are more risky for being cancerous. These are lesions that have a diameter greater than 6 millimeters. And E is for evolution. It is important to pay attention to whether these lesions are changing in size, color, or shape. This talk overall is just a reminder to talk with your healthcare providers about what preventative cancer screenings are right for you and what the recommended age is to begin screening for you personally. The Riverside Online Cancer Care website has a wonderful guide on cancer screening and prevention. We do have some handouts for those of you that are in person today. And I would be happy to open the floor up to any more questions.
A couple of online questions. One was, what do you define as first degree family?
First degree family is mom, dad, brothers, and sisters, and children, of course. But a lot of times when you're defining first degree relatives for cancer risk, it is your parents who may have passed something on to you or your siblings that have the same.
When can PSA testing be stopped?
So prostate-specific antigen testing is again a decision to make with your primary care or urology provider. There are some risks associated with prostate surface antigen testing. It is a fairly straightforward lab draw, but if your level is elevated, it does require further investigation. This can include biopsies of the prostate, ultrasound, and further imaging. The older you get in age, the higher your risk for prostate cancer. So while I can't give you a specific age like 65, which we say for average risk patients for cervical cancer is when we stop screening, it is based on your first degree relatives, your inherent risk, and the decisions you make with your doctor. Again, if you are 75, 80 years old, living a high functioning lifestyle, and you feel as if you would be willing to undergo the treatment for prostate cancer, I would continue your screening. If you're 80 years old, not living a high functioning lifestyle and are not sure that your body, your mind could handle the treatment, that is a decision to make with your primary care doctor to stop screening prostate cancer.
When you were talking about colon cancer, you mentioned the 2 at-home tests. In what instances would you recommend that you do that?
So I would always recommend a colonoscopy to screen for colon cancer. There are some patients that, rightfully so, are worried or fearful of having a colonoscopy. It is a medical procedure. It does require sedation, and there are risks. If you absolutely will not undergo a colonoscopy, that is your decision. Would we recommend it as first line? Absolutely. But if you are not going to have a colonoscopy, that is when I would recommend either doing the FIT testing or the Cologuard stool samples, because some screening is better than no screening.
I think that's all our questions.
Thank you, guys.
Thank you.